name is Anissa Mitchell. Today we're going to be talking about Parkinson's doesn't discriminate. This is something that we're doing in collaboration with our friends with Kyowa Kirin for Parkinson's Awareness Month, and it is Minority Health Awareness Month. And we often see Parkinson's depicted as an older white male, but we know that Parkinson's does not discriminate regardless of age, gender, race, ethnicity, or sexual orientation. So today we want to talk about some of those experiences of different groups of people that are often underserved in terms of care or underrepresented in research, and why this is actually important to the greater community. So thank you for joining this conversation. We do encourage you to make comments in the chat or questions in the chat as we go along. I'm excited to have 4 panelists that are going to be part of this discussion today. First with us is Dr. Pinky Agarwal. She is a board-certified neurologist and movement disorder specialist at Booth Gardner Parkinson's Care Center and chair of medicine at Evergreen Medical Center in Kirkland, Washington, and is a clinical professor of neurology at the University of Washington in Seattle. As well, we have Dr. Jose Cabassa, who is a Parkinson's specialist, a former assistant professor of neurology, who currently runs a private practice called Moving Brains Neurological Care, and is the president of Moving Brains Foundation, which is a physician-moderated, moderate to high-intensity skill-based exercise fitness program run by professional athletes. Also with us today is Jason Flatt, who is assistant professor at the University of Nevada, Las Vegas School of Public Health, Department of Social and Behavioral Health. Jason has over $5 million funded NIH research portfolio, working to better understand the health concerns and needs of diverse sexual and gender minorities, people living with Alzheimer's and Parkinson's disease, and their care partners. And lastly, we have Dr. Hiral Shah, who is an assistant professor of neurology and movement disorder specialist at Columbia University Irvine Medical Center in the Division of Movement Disorders, and is medical director of the Parkinson Foundation Network of Excellence. It's a mouthful. You all have such wonderful credentials, so welcome to our discussion today. And I want to just go ahead and kick this off for everyone that's joining, just kind of help all of us to understand some of the language and terms that might be used. So if we could just start with the general definition of what race and ethnicity is, since they somewhat overlapping terms, I think, whether you can define the difference of the two. And this is open to whoever might want to answer that question.
I can take that one initially. So, there is confusion about race and ethnicity, and race is sort of more narrow-based, and it is more about one's physical characteristics, like physically what are one's biological attributes. And that could be color of one's skin, it could just be their physical stature. And so commonly it's more broad-based, like people could say one's Black or Afro-American, Asian. But when you go into ethnicity, it's much more broad, much more subtle, and it's more based on one's cultural expression, place of origin. So say for the Asian group, right? For someone, it could be, okay, you're Asian, but within Asia, you have Southeast Asia, you have, Southern Asia, Central. So you have so many subcategories, different countries with different cultural identities, food habits. So it's much more subtle what ethnicity is, and oftentimes what a person self-identifies as, what ethnicity they belong to.
I don't know if anyone else wants to add to that.
Just to give a quick example here. I am certainly by definition, I guess I am Caucasian or white, but I am ethnically Puerto Rican. So I've been, all my life, my culture is it falls within the Latino category, and I was born and raised Puerto Rican and Spanish speaking, but certainly, and as in the Latino culture, there's different that you see people from different races, for example, right? Even within the same countries. So it gives a nice example of some of the differences. Yeah.
And I just, to add to both of those comments, which I completely agree with, just to underline that race is often thought of as a social construct, that it's, something that we as society has created these rules. In the African American community, I know that historically there were these, if you had one drop of blood, that were you designated as African American or not. And I think that unfortunately, these social constructs that may have been developed for a variety of reasons, probably in some cases to disempower entire groups and communities of people, I think they've led to the perpetuation of many misconceptions as well as many biases and stereotypes. And so I think by acknowledging that race actually doesn't have really a genetic basis, like there's not really a distinction between different races, I think that it just reminds us how, in some ways, these racial categories have gotten us into a lot of trouble and have led to the, health inequities and disparities that we see, not only in Parkinson's disease treatment and care, but across the board. So thank you for starting the conversation with the definition so that we can all be a little bit on the same page and have a better understanding of what it is that we're speaking about.
And you mentioned bias, and that was going to be kind of my next question is, we're going to be discussing discrimination in care, representation in research, then I think we should include an understanding of bias. And I'd love if you could unpack that a little bit, because I don't think it's just one thing, right?
So I think I would like to kind of build on what Dr. Agarwal started in terms of that broadly, bias refers to this, could be a prejudice, tendency, an inclination, or an assumption that can influence your decision making and your perceptions of an individual. And that bias can be explicit or implicit. And I know in medical education, there's been more discussion about implicit bias lately, where it's referring to the biases that people may have that they're unaware of. I recall a training exercise where we were shown images of various people, and the group was asked, what do you think this person does for a living? And for instance, there was a woman in a sari from India, and it turned out that she was someone that was highly educated and perhaps had multiple degrees. But when you initially observe someone who's in a sari, who's an older woman, perhaps the assumption is that this is someone with limited education, or so these assumptions that we either are aware of or unaware of that lead us to not only change our behaviors and influence the way we interact with someone, but that they create these prejudices, unfortunately, for certain individuals and groups of individuals.
Jason, I actually would love to hear from you and your perspective, how bias is demonstrated in the LGBTQ community.
Yeah. So I think similar to the other speakers have talked about, right, in terms of, I think of intersecting identities or intersectionality. And so there can be different forms of sort of bias or discrimination that people might perceive in healthcare. So examples might be assumptions about certain health concerns, or assumptions you heard, right, about people's understanding or their education or literacy. And I think an example for LGBTQIA plus people might be, right, I'm coming actually for my care around my Parkinson's. Why are you asking me about an HIV test? Right, and making sort of assumptions that, right, I'm at risk for HIV, or I need to know my status. How is this related to my care? or examples we've heard for our transgender community members where they go to seek care. I have a story of an older trans woman who went for care because she was having shoulder pain, and the clinician wanted to examine her genitalia, right? And she was under like, how is this related to my shoulder pain? Why do you need to know whether or not I've had gender affirming procedures? How is this related to my care? And so there's those kind of pieces that can be really difficult for the community or just another issue we don't often talk about is just aging, right? And so this assumption that maybe because you're an older person, you can't hear well, or that you lack understanding. And so they either talk to you very slowly, or it can appear like they're screaming at you because they're making an assumption that you can't hear them. This can be really triggering for people, especially people that have experienced past trauma when they seek care. And so these challenges, I think, are something that healthcare providers need to really be aware of, and why we need to really think about our own kind of cultural humility and cultural competence in providing care to people living with PD from diverse populations. This is going to make care better for everybody. And so that's a piece we always want to be thinking about.
And I'm so glad that you said that, because the whole point of us having this discussion is that it impacts everyone. This is important to everyone. So, and I want to weave that whole, message throughout today's conversation, because it is important, regardless of whether you in particular are experiencing any kind of discrimination, it does impact you. So I want to know, because what you were saying kind of leads me to my next question about some of the unique challenges, each community, each person might experience in getting diagnosed. You come in with one symptom and they're asking you something completely unrelated, and getting access to treatment. So, access to movement disorder specialists and people who are competent. And that can be, whether it's somebody in the LGBTQIA plus community or anyone. So I would love to hear from any of you from those perspectives that you have.
Yeah, I'm happy to share again, and I'll give a definition of the LGBTQIA plus, just so we're on the same page. So it's lesbian, gay, bisexual, transgender, queer, intersex, asexual, as well as additional identities. So people may use a term that is not included in those letters, but does identify as a member of the community. So we use it as an umbrella term often. So for LGBTQIA plus people, in terms of getting a diagnosis, but also care. So there's a lot of, and I would say this applies to much of our diverse communities. So it isn't always specific to LGBTQIA plus people, but we find this more common. And so we know our minority communities have less access to resources. That could be income, that could be knowledge about where to seek care. Those can be issues with transportation, as well as then the broader trust piece of maybe they haven't had great experiences in the past with interacting with healthcare providers. So given just some of those challenges, they may be reluctant to seek out care when they're having a problem. We also know for this community, they're much more likely to be single and living alone. And so many times they may be just fearful, what happens if I get a diagnosis of PD? Would I have to go into a long-term care setting? And then how would I be treated in that setting? So fears of sort of not understanding the care plans, what would be, some of the patient autonomy pieces that would ensure that they could remain, living independent. Those are going to be a piece. And then for our minority communities is just the cost of care. So how do I find a provider that takes either insurance, or can I afford to pay out of pocket? And how do I navigate some of those pieces? And so I would say this is why we need to be doing greater outreach to our community, but also developing resources and panels like this that talk about, right, some of the unique needs of our community, but also how can we connect them to providers that they can trust, as well as resources that they know will be welcoming and really with their best kind of the best needs and sort of thoughts about their care are put at the front of it.
I'd like to add something to that from the Asian community perspective. You know, for them, one of the unique challenges ends up being language. And, you know, a lot of the time when you see, right, we'll put things either in English or maximum, you know, in Spanish, maybe in the waiting rooms. And Asia has so many languages, right? It's almost impossible to even put in all the languages from Asia. So what ends up happening is, you know, we feel like we've met our diversity quota when we've put some, you know, Spanish consents or Spanish language information brochures there. And then, you know, most of the time we do try to have interpreters. Sometimes I've seen it the other way too. There'll be someone who's fluent in English, but just because they have an Asian name, it'll be assumed that they don't speak English and there'll be an interpreter. So to be open to thinking that yes, this person could be first generation, second generation, they could be from Asia, but they could be fluent in English. So those assumptions and those biases that Dr. Shah also mentioned, right? That we make assumptions about how people dress or where they come from. For us, you know, because we are located like 5 miles from the Microsoft campus, we have a lot of immigrant population that's highly educated, very fluent, and sometimes assumptions are made, oh, you know, they're from another country, they probably don't understand the healthcare system, whereas some of them are very tech savvy and they can go and do, you know, their research, they're very up to speed, they know the latest research out there. But we also have those other people who are actually your first generation immigrants and who have the same challenges that Jason mentioned, right? Like, you know, living alone or access to transportation, not understanding the healthcare system. And in fact, the healthcare system is very complex, right? Some facilities have just professional billing. Some have professional and then they have some facility fee billing. It's really very, very hard for some of these patients to understand. So then they'll get one bill which they understand, then another bill that they don't understand, then they don't understand how many more bills are going to come their way. So the natural tendency is, okay, let me not seek any more care until I actually figure out how many more bills I'm going to get. So I think really taking time and you know, trying to explain to people what those bills are, what their commitments might be, because then the patients get punted around, oh, you call your insurance, we don't know, and the insurance says, well, we don't know, your provider's office is different. So some patient navigators who can actually explain things to people about how the billing system works.
I might build on what Dr. Agarwal and Flatt have discussed, you know, in terms of some of the unique challenges that different communities face in terms of getting diagnosis and then having access to treatment and care. So in what I've learned about through the literature, as well as in my experiences with patients that I've worked with, is in the African American and Black communities, individuals often face prolonged delays to diagnosis of Parkinson's disease. So there's a lot of data about when someone finally comes to diagnosis, they're much more advanced in their condition and have higher rates of morbidity. They're less likely to be seen by a neurologist or a specialist. They're less likely to be started on medication at diagnosis. They're less likely to be referred to rehabilitation services or even advanced services like deep brain stimulation. And I think there's several issues, you know, that contribute to this. I think one of them is the mistrust in the community. I think often it's the norm that individuals in these communities are told to dismiss or put aside their medical concerns. It's not the norm to seek regular medical care or preventive care. Within families, there have been experiences of being exploited, as well as the historical exploitation of the African American and Black community. So that, I think sometimes providers or clinicians think this is a historical issue, but it's really a contemporary one that's alive and well in the communities that we need to be aware of and work hard to try to build that trust and address how we're doing things differently, so that we do not exploit individuals and meet them where they are. I also think that people are hesitant to seek care because they're concerned about what this means due to stigmas. So what this means for them professionally, if this will result in loss of employment, what this means in terms of their cultural, or excuse me, community stature, as someone who's well respected. And I think many of these issues, just being a member of the Southeast Asian community, from India, I know that that's true in our communities as well, that people are very reluctant to speak out about Parkinson's disease. It's easy to talk about diabetes or high blood pressure. This is normal or acceptable. But speaking about brain health conditions and things like Parkinson's is not the norm. And people very frequently hide the diagnosis, are secretive, and become isolated. So those are some of the challenges that I've observed. And, that, of course, leads to worsened treatment outcomes. So.
And I agree with Dr. Shah that we also have to be a little sensitive about the words we use to elicit symptoms. For
Yes.
some communities, using the word dementia or depression are sort of not acceptable. And we want to get the medical information, but in a socially acceptable manner. So in some communities, it'll be, okay, do you feel sad versus are you depressed? Or do you feel like, or as a family member, do you have dementia versus, or do you feel you're a little bit more forgetful than you were a few years ago? And then, a lot of the non-motor symptoms also can be about bladder, bowel, sexual functioning. And in some people, some cultures are not open to discussing this with family members around. So again, we want to get the information, but in a culturally sensitive manner. So we may want to forego those questions, or find a way to get that information without actually asking, what's your sexual functioning and things like that. So just that cultural sensitivity that some people may not want to share when other family members are there.
I think I wanted to chime in as well, and from the perspective of a community neurologist, and in the Latino and African American community, I think the understanding, talking more specifically about Parkinson's, is especially when there's not a tremor, which is what most people associate with Parkinson's. Trying to interpret the symptoms of Parkinsonism often sometimes becomes a challenge, not only as the patient is experiencing them, but even as doctors, whether even with just different variations in Spanish, for example, in specific colloquial sayings of how you refer to something. For example, a spasm in Spanish sometimes gets referred to as numbness, versus sometimes it's a muscle. It's muscles is getting tight. So it's just even the breaking down the symptoms, and tying in some of the non-motor symptoms that might not have been initially even associated with the conditions. I mean, it becomes challenging, and hearing the person, listening to them carefully, and trying to pick up on some of these nuances, sometimes can be helpful, and breaking through, first identifying that what they have, and then trying to explain it back to them.
And if I could add just one more point that I didn't want to leave out, is that I might have been focused initially on some of my comments on reasons that the individual or the family may not come to medical attention. But again, just to remind us that providers also have these biases and lack of recognition, which leads to the misdiagnoses. So often I've heard numerous stories of individuals from the Black community expressing that I knew something was wrong, I kept seeing doctors, but physicians often, or allied health professionals as well, may have this image of Parkinson's affecting the older white man, as you started the session. And this leads to this, lack of recognition of what might be going on, and consideration that it could be Parkinson's disease. So I just think we need to be mindful of that. And I think that for me, because it is a challenge when you're meeting with individuals from different communities to know exactly how to strike that right note. But I find that if you try to just listen, as Dr. Cabassa was pointing out, really intently, and be patient and try to meet the person where they are, whether that means culturally, geographically, help address their priorities, that it allows for that conversation to open up. And then you can build from there, that all of these questions may not be need to be answered on the first meeting with this individual. But if we at least have it in our minds that, when someone is quiet, that they may be reluctant to share, as Dr. Agarwal pointed out, because they're embarrassed, that it's not comfortable for them. Just having that consciousness of that fact, I think, helps a lot.
And everything that you all said, there's a lot of challenges and a lot of barriers from both sides and stigma. And I do want to go back just for a second because Jason, you were talking a little bit about some of the stigma and isolation in the trans community. And, they also are part of other communities in addition to being in the trans community. And obviously, when you're dealing with Parkinson's, you're dealing with a lot of changes in your body. And you have that with, with transitioning and, gender affirming care, isolation, a lot of stigma in the community. Like, can you just speak to maybe some of those issues specifically, access to care or confidence or trust in the healthcare community? I can imagine would be very challenging.
Yeah. So some of this does apply. I think specifically it affects our transgender and gender diverse communities. But we're also seeing in some of our research that it affects all LGBTQIA plus people, as well as expanding into minority groups that are fearful of, right, if they're so the big issue right now that's happening is that across much of the United States, mostly in the Southeast, they're passing laws to restrict access to gender affirming care for youth. But when these laws are being written, and I think someone mentioned recently, it's like over 80 laws have been introduced this year to restrict access to gender affirming care in many states. Some of these are not getting passed, right? But the legislatures in those states are moving this forward. And so in some of the states, when laws are passed, they will actually restrict access to care for everybody, right? Or you have healthcare providers that aren't sure how to navigate these laws in their state. And would this potentially set me up for a lawsuit? And so this is creating a lot of fear, both on the provider side, but on the patient side. And so imagine a person that's fearful about, so I know I'm an example of a transgender woman who is fearful, like when she goes to see her movement disorders clinic, would they be concerned that her gender affirming hormone therapy would interact with any of her medications that she would need to be taking, right, to manage her PD symptoms? Or would they try to take her off of those gender affirming hormones? And so her big thing was like, I am not going to have this affect who I am, right? And navigating that. And so she was reluctant really to seek out care. She ended up finding a provider. One of the great things that people don't know, through the Human Rights Campaign, they've created a long-term care index, as well as SAGE, a national LGBT aging organization, has the LGBT Aging Resource Center. And they've been building a list of affirming providers across the United States. So most of this I am not aware of any that's been focused in like movement disorders or neurology specifically, but there are some resources. And this way community members can find an affirming provider who then hopefully can refer them to someone else. But these fears have definitely resulted in delays of getting a diagnosis, delays of seeking treatment. And then you bring in all the other kind of barriers that people face just in their daily lives that maybe aren't necessarily related to their Parkinson's, but are related to other challenges, whether that's income, transportation. A lot of the clinics want you to have a partner or a caregiver to bring with you to talk about your symptoms and give some insight if things are getting worse or how were they compared to, you know, maybe 6 months ago. And for many LGBTQIA plus people, they don't have a person like that they can bring. So that also creates some major barriers.
So more barrier deep dive is I want to talk a little bit about whether there's any difference in symptom presentation in different people. And if we're struggling with the language in going to providers that know how to ask the right questions or are good listeners, like if not everybody presents as the typical person, how do we overcome that? And is there any difference or are there differences in symptom presentation in different people? I'm not just not that it's a heterogeneous disease, but like, is there differences in the African American or the Asian communities? Are there any presentation differences?
So I could start with that. So, in some groups, there are certain genetic variations that are more prominent. And in these genetic variations, and depending on the combination of these genetic polymorphisms you may have, presentation can change. So we know that in some ethnic groups, like people who are, from North Africa or Israel or some of those groups, sometimes there's more predominance of the LRKK2 gene. There may be increased prevalence of GBA mutations. And so in patients with, say, GBA mutation, there may be differences in cognition. So memory may be affected a little bit earlier. In some people, such as with the LRK2 mutation, it can present very late, but you may have quite a family history of Parkinson's there. There's some early literature that some people from Asia may have less tremor may not have tremor as an early presenting sign. So yes, there can be changes in how PD manifests. PD itself is a spectrum, which, we are lumping together a bunch of symptoms, and these symptoms can be different. And depending on genetic variations and ethnic changes, presentations can sometimes be different.
Yes, from the perspective of the Latino community as well, and I think Dr. Shah mentioned some of this. So I guess one of the presentations is that a lot of times there's been delays in diagnosis, so the Parkinson's itself can be more advanced, more comorbidities to kind of sift through. So it can, at times be more challenging, and to even understand and the role of other medications that might be contributing to the Parkinsonism as well. So it's you can become challenging as people have these conditions for longer. Just even basic things like having maybe more arthritis pain or more, just having unmet conditions not properly treated, eventually they have secondary consequences as well.
I might add that so I agree with what Dr. Agarwal and Cabassa indicated, but I guess one other caveat I might say is that, for instance, I think we would agree that a GBA mutation version of Parkinson's probably looks similar regardless of what ethnicity or race you are, and that there may be this belief or in the literature, it's reported that, people that are Ashkenazi Jewish, for instance, have a higher rate of LRRK2 and GBA mutations. However, in the last year, they discovered a variant of GBA amongst an African American community. So I think also we want to be sure that we don't make the mistake that we don't look in these populations. And I believe the same is true. Dr. Cabassa could probably correct me, that in Puerto Rico, they also identified a community that had a prevalence of LRRK2 mutations as well.
Yeah.
And so, these communities and the what's the anthropological word of the migrations, through the genetics and how this all shifted, is that we also want to try to encourage all ethnic groups and all races to participate in genetic testing so that they can all afford the advantages of knowing their genetic status. That Parkin PD is thought to be equally prevalent across all ethnicities and races. So I think Parkinson's is probably this spectrum, as Dr. Agarwal described it, that there's a range of phenotypes, or the way that people physically appear, and we're lumping them all together. But I think we have a lot more to learn as well.
So I guess that leads into a question of research. Like, if we have poor representation of everyone in research, then we have an incomplete picture of Parkinson's disease. And so I'd love to learn. I read one report that only 8% of participants were non-white, and another one, 17% of participants were not white. So what are some of the challenges as far as getting diversity in research? I'd love to delve into that a little bit, because I think it's important for everybody.
So I could start with that. So, there are a lot of challenges. Some are from the community and some are actually regulatory. So from the challenges from the community are already what we discussed: challenges to care, like, loss of wages, loss of transportation. And some communities can find it hard to understand that, yes, research is not something they get billed for, because then they're so used to unexpected bills from other places. But the bigger challenges are language. And what happens is that if you look at the language of various regulatory bodies, in some, they write that if you were to enroll someone who speaks another language, which is not the majority language, typically English, then they are vulnerable population, which means it gets put in the same category as prisoners, or as people who are not capable of giving consent. And so that makes investigators sometimes very hesitant to enroll these people, because a lot of people are not somewhere black and white. People have different fluency when they have English as a second language. So one is less likely to approach someone who may be able to understand the consent. But if you think, oh, could they be categorized as fluent in English, not in English, you're more likely not to enroll them, because the language says that they're vulnerable population. Also, we know in research trials, consents are often provided automatically in English and in Spanish. Most of the times, if we approach a sponsor and say, can we have in another language, then they'll say, oh, it'll be on a case-by-case basis, which means that if we have an interested patient, then we have to approach the sponsor, then they'll translate the consent, which is often prohibitively expensive. So some sponsors will say no. In some, they'll translate that may take weeks or months. And then after all of this, you approach the patient. By the time the patient's forgotten, moved on, if typically we would give the consent, all this would happen in 24 hours or 48 hours. Now you're talking 3-4 months later. By that time, the patient's forgotten the initial conversation. So they're much, much less likely to say yes to a clinical trial.
Any of you other panelists have any other thoughts about this?
So I think another major concern is trust. Just as trust is so important in clinical care, I think there is a lot of mistrust of the medical community when it comes to research. And so if someone is approached about research, I think the often quick answer is no. There's also a lack of awareness of what the potential benefits could be to that individual or for their community. I think that research itself is, as Dr. Agarwal said, there's certain words that you don't like to use. And I think the word research is also one that's very stigmatized and taboo for some communities where they don't even want to go there. They're not ready to hear about it. And so I think that's another challenge. And then I would say, it's not a priority and there's many competing demands that people are serving as caregivers. They have other responsibilities. They may be working or caring for an elderly parent or children, grandchildren. So I think they don't have that what's not I don't want to say interest, but it's that they don't have that that readiness to be ready to participate and understand what research involves and the various logistical challenges of, it is a very time-consuming process often to travel and be a participant in a research study and have a care partner. All of that is very resource intensive.
Just piggybacking on what Dr. Shah said in terms of trust, I mean, so sorry for my perspective, looking at different communities through New York City, and as we have discussions like this about minority populations, my concern has to do with with the balance of research versus treatment, right? I mean, as we are there's this incentive that, of course, we are recognizing the importance to really study all minority populations. We want to ensure that the incentives for for the medical systems, for the doctors, are there to really have support to be able to enroll. I mean, just as we talk about trust, if the patient ultimately trusts us, then finally to participate in research, just to make sure that we're taking care of them and that we're not, just enrolling them and not necessarily providing the right care at the expense of the research. So it's a cautionary plea, I guess, from my end, as we try to strike a balance, because we understand that both all these populations both need to be involved in research, but they also need good care.
And that just reminds, and I'm sorry, Jason, I see you're about to speak, but I just wanted to say that sometimes then when you do have individuals or families that are interested in participating, I think that we want to be cautious not to overburden those individuals, to recognize that they can't do it all for all and be representing everyone in their community. Because I do think even in the South Asian community, there's, when you look at participation, even at events for the Michael J. Fox Foundation, Parkinson's Foundation, various foundations and events, you see that there predominantly is a white population. The minorities are simply not present or represented. So we want to be careful also not to then overburden those that are standing up and participating.
Overall,
Yeah.
trial. Sorry, Jason, did you want to go? Or,
Oh no, go ahead.
So I think we also have to look at how these clinical trials are designed, because oftentimes, okay, there is some amount of data you need for the primary efficacy outcome. But then there are what people call exploratory outcomes, where they just want to get data and explore and help it in development. But because of those exploratory outcomes, sometimes the clinical trial visits become very long. And it's unfair to patients who volunteered for a particular, say they volunteered for some symptomatic treatment or some possible neuroprotective treatment, that they're being able to ask to give all these hours of time for some exploratory outcome. And we really need to design clinical trials that have some reasonable length, because some of these are all day affairs. So patients, some of them, it's easily 6 hours. Sometimes if there's some delays along the way, it can be 8 hours. And just because someone volunteered doesn't mean like they've signed off their life to this research trial. So, and I know trials have now started involving patient advocates and ambassadors, which is great, but we really need to keep an eye on the length of these research visits, and that will help participation. I mean, people have other commitments at home. Just because they committed to a trial, their life didn't pause, right? They still have to do everything else on the other days. And then suddenly there'll be an amendment, then they'll say, now you need to come for all these extra lab work. And then your option is, okay, you did all this, you committed all this time, and either walk away from the trial and that time went waste, or now, just come for all these. So once amendments are made in a trial for what a patient didn't initially sign for, all effort should be made that someone's going to the patient's home, through a nursing agency arranged by the sponsor, to go and collect extra lab visits, rather than just ask the patient that, okay, now we make this change and now you have to come 10 more times for these lab visits.
Jason, I think you were going to say something.
Yeah. So I wanted to add to I think some of the discussion we're having are about inclusion and then also trust. And so for the inclusion part is, especially when I think of LGBTQIA plus populations, we need to ask about sexual orientation and gender identity. There's a big reluctance, I think, in researchers just more broadly, who maybe not working with minority communities, don't think that these types of questions are important. But when we're thinking about health disparities and challenges in access to care, it's really important that we ask about diverse identities. So that's a big piece. And then the trust piece is, I think for many of those that do research, they think like, oh, people just want to do this research because it's giving back. And that's not necessarily the case. And often what happens is researchers haven't thought about the barriers for our minority communities in participating. They also need to understand what's the purpose of this, and we should be paying them for their time. So a piece of expecting someone just to volunteer their time, volunteer, maybe they have to cover the cost of transportation. That's an unfair barrier for those that are experiencing either transportation or economic challenges. So there's that piece. And then I think that a big gap is in terms of building relationships. So are researchers going to give their time back to communities? Are they going to show up? Are they going to share what they're learning? Are they going to go back and talk about, here's how Parkinson's is affecting diverse communities? That's often missing. So what many people say is, oh yeah, I donated my time to this research, but I never heard anything about it. I don't know whether it's a trial, did I get the placebo or did I actually get the treatment? Or, examples of like, I don't know how they're using my data. I have no clue what's going on with that. And so those are huge gaps. And then finally, another piece that's in this is making sure that when you're designing research teams, whether it's doing outreach, doing the assessments and disseminating the research, people want to see people like them. So your research team should represent some of the diversity of the communities you're working with. And I think that that's a piece that's often missing from a lot of the research that's happening.
You brought up a lot of really good points, so thank you for sharing that. So I do want to switch gears just briefly to talk about some of the more practical aspects, and that is how different groups might deal with advancing disease, long-term care needs, and caregiver burden. Is there any difference in who tends to be the care partners in different groups of people? And, are there some that are more isolated than others? So I'd love to hear from each of you some of that perspective.
I think that historically Latinos, the caregivers tend to be family members, and I think that's oft that's a I guess in my practice that's always I guess it's an added bonus, but it can be a double-edged sword as well. I mean, you have to be careful. But in other populations that lack of family support, really becomes, a big problem. I mean, a big barrier to their care.
I would agree that it's very similar in the Asian population. Oftentimes, caregivers are family members, and people don't like it if you bring up things like, adult family home or assisted living, etc., because it's counted a little bit more like, oh, my family doesn't want to take care of me, so they're abandoning me and they're putting me somewhere. So, and then also just bringing up things like hospice care, palliative care, all of these you have to be very cautious about which, how you're presenting it to some of these groups, because again, can be perceived as, giving up, you're giving up on me. That's why you're bringing up these issues. Or even things like power of attorney, healthcare power of attorney, just because sometimes these people have grown up in a different culture, and they haven't heard these words so often. So oftentimes healthcare power of attorney, people just think, oh, this is my will, like financial will. Sometimes people don't understand healthcare is different, and financial wills are different. And then sometimes even how you speak to a patient, sometimes in the Asian population they'll bring family members in. And generally, if there's a medical person in the family, the patient would want, or the family would want you to interact with that person, whether it's by phone. So even if that family member hasn't come, if you say, yes, sure, if they say, oh, this so and so couldn't be here because they're with patients, and you say, oh, but sure, I'm willing to talk to them. And then they feel, okay, that person is also, you gave them due respect, due, importance, so that generally there's, instead of making a decision now, they often go away, discuss with other family members before they agree to some major decision making. So I think those are differences between, you have to kind of broach the topic and be a little delicate about it, and know to back away if it's too much for them during that visit.
I would add, for the LGBTQIA plus community, I've shared rate around more than 1 in 3 are single. So they're less likely to have a caregiver. What we're hearing is sometimes caregivers are more of in non-traditional roles than what we would expect. So that caregiver might be a friend, a neighbor, a chosen family member. And oftentimes, right, when they're navigating some of the legal or policy related pieces around accessing care, they may not have those documents in place, like a power of attorney, living wills. Any of those pieces often aren't in place. So there's some really unique barriers for, especially, I think, thinking about caregiving, access to long-term care. You brought that up. So one is the cost, but I think then I've shared already, there's a huge fear that if I go to use the long-term care services, I'll be discriminated against. And for many older people, they've already experienced, they've had discrimination, whether it's from other people that are using the services or from the staff. So they might experience, we have an example, I know someone who used home care services, and the home care aide that came in viewed that the person being transgender was against their religion. So the person said this caregiver started throwing away the person's girl clothes, right? And basically trying to put their belief systems on the place of their customer and the patient, right, who needs this care. And so these are major challenges for LGBTQIA plus people living with Parkinson's, that, you know, it impacts both the caregiver, but also the individual, and why they're reluctant to seek out services.
I'm not aware of specific data regarding, you know, the challenges that caregivers face in the African American and Black community. I think it simply hasn't really been examined in detail. I think there's one article that came out this year, but I will say that I think it just underlines the importance of examining the caregivers at all, you know, to always be thinking about the burden that the caregivers are facing, and to make sure that during visits that individual is being addressed and acknowledged, and also that that individual needs support, and there needs to be structures in place. So I know that that's something that groups that I'm working with are trying to establish, so that care partners have a safe space to share their concerns and connect to other people that are in a similar situation, as well as, so because the care partner and caregiver also has unique insights into what's going on with the person with Parkinson's. And so I think it's just important that we be thinking about and paying attention to the caregivers and their needs as well.
Thank you for sharing that. Well, this has been a fantastic conversation. There's a lot of work that needs to be done. I really do appreciate you each giving your perspective and your expertise. I want to give you a last chance to give any last words, or share something that you may be doing to help move the needle and help some change occur for our audience.
I would say that, you know, historically, we've wanted, you know, you have to go out in the community and interact with people. So whether the way we try to do it is, when we were focusing on the Asian population, we were going out to health fairs, we were going out to, say, some uh, senior, either assisted living facilities or senior centers where there were particular ethnic populations, and we were trying to bring some things translated in their language just so that they could understand. At some talks, we've had translators who've been translating while we are giving the talk. So ultimately, it has to be going out to the community rather than expecting the community to come to us and somehow build trust that way. Trust comes when you kind of make the first move and reach out to them.
I wanted to share, we have a current study that's funded by the Michael J. Fox Foundation, and we're recruiting LGBTQIA plus people living with Parkinson's disease, as well as caregivers of LGBTQIA plus caregivers. And so we're doing a survey. We also have a website. It's on rainbowsofaging.org. But if people are interested in PRIDE or Parkinson's research with inclusion, diversity, and equity, they can give us a call. We have an 800 number. It's 1-888-709-7689. And we plan on, once we sort of meet our recruitment goals, so we're trying to get 250 people, we're going to then be disseminating what we learn about the unique needs of LGBTQIA plus people living with Parkinson's, as well as caregivers. And so I'm so grateful to be a part of this panel and be with my esteemed colleagues who are doing such important work. And I'm really grateful that you organized us and had this discussion today. So thank you.
So yeah, thank you for having me, and it was great to be surrounded by so wonderful people. I with what I'm doing with Moving Brains Foundation, I mean, we're trying to tackle some of these problems, you know, that we see, trying to really, improve care for everybody, and through our training program, for example, our exercise training program, we're making sure that our caregivers do some exercise along with us. So for example, so we encourage people to not only participate but to bring their caregivers. We created a space for them as well, and we really just we really want to our organization is currently providing free training for everybody, just to make sure that we can reach as many communities as possible. And we're trying to expand and reach all neighborhoods, or expand our access to just involve a lot more people as we move forward. But thank you.
Yeah, and thank you again. And I also am really thank you for the honor to participate in this panel. I also learned a lot from my colleagues. So at Columbia, we have been working, as Dr. Agarwal said, it took time to build trust and to establish a relationship and partnership with community members. So we've tried to adopt a community-based participatory research approach where we really have equal partnership with community members from conceptualization, implementation, and interpretation of study data. After working with the community for about 5 years, and working in a church, which is an implicitly trusted member of the community in Harlem and Hamilton Heights, we developed this PD Movers book, and our approach was to utilize storytelling as a culturally sensitive method to share information. And the book that we developed was accompanied by illustrations. So with the illustrations being a manifestation of the importance of representation. And, that tool has been really met with high levels of enthusiasm. People love it when they look at it, and I think it's because they see themselves in it. But much like what Anissa was referring to at the beginning of this conversation, many of the lessons and the themes are universal, and they apply to all communities. But we've tried to take an approach where we're really trying to reach and teach individuals in the African American and Black community. There was a question in the comment section, and we could probably have a whole session about the distinction between African American and Black. And I think that it warrants a more deeper discussion. But I think what I'll say is that we're trying to meet people where they are and how they identify themselves. The more individuals and communities I've worked with, I recognize that some are comfortable with the terminology African American, other are more comfortable with the terminology of Black. There's a lot of history, and there's a lot of what's the word I'm looking for? Beyond history, I think there's a lot of negative and positive connotations that go along with that. So I always try to be inclusive, and we're actually thinking about dropping using these terms entirely, and we're constantly having a debate and evolving in terms of what is the best terminology, because ultimately we want to be inclusive and make sure that people feel respected, seen, and heard. So thank you again for the opportunity to participate in this panel.
Well, thank you, all of you. It's been a fantastic conversation. I think we could probably spend another hour going through this, but I know you've given a full hour more of your time and your expertise, so thank you so much. And I want to thank Kyowa Kirin for allowing us to have this opportunity to have this particular conversation. It's super important. There's a lot of work to be done, and I appreciate the fact that it's constantly evolving. So thank you for your expertise. And I'm going to invite everyone, if you're willing to turn on your camera, we want to send them off with a wave of gratitude. Just thank you so much for your time, everyone. Dr. Cabassa, Dr. Shah, Dr. Agarwal, Dr. Flatt, thank you so much for your time today. Take care.
Thank you.